stay here, please. Can I now invite both Stephen Wu and Natita Pasteur to the floor to again go through the discussion we had yesterday with a Q&A session. So could I invite both John and Neil, wherever Neil is, to the podium for the Q&A session.
Okay, microphone on? Is it on? Is it? Okay.
It works. Well, thank you so much for staying here again. We are here to have fun. Then let's start with the questions, but for sure, open for discussions. And as I said yesterday, if any of you want to have an open discussion, just ask for the microphone. The other point is that there are a few questions that were not answered yesterday, and the team here will be responsible to prepare the documentation around that and send you the answers. Then no worries for the one that they don't have received the answer during our lively session yesterday. Saying that, I will pass to Steve to initiate the discussions.
Thank you. So I see we have quite a number of very good questions from the audience, and I'm sure we'll have plenty of time to get to those. But before we start, I just want to again say thank you to our outstanding speakers who are all. I have the good fortune to say they're all friends of mine. To Neil and John and Roberto. And I think one of the great things about today's session was that not that yesterday's session was not great, it also was, but there was I feel even more of a unity of the topic today, talking about we've talked about looking at things holistically, both in terms of the first 1,000 days before birth, including before birth and the first 2 years of age, and how so many factors and so many experiences and exposures, especially nutritionally, affect the entire lifespan after that. And we've also talked a lot about, in a holistic sense, how the baby is not just the baby by itself. It's the baby, it's the mother, it's the father, it's all the caregivers, and it's a very social environment. So I think it's great that those threads have gone all through all of your talks. And I'd just like to start out with one question, which I guess is to all of you. It seems a very big challenge to differentiate between those fussy crying kids who are going to be okay, as John mentioned, and who do not need very intensive treatment, and those fussy crying kids who have an underlying problem, specifically who have allergy and immunologic issue, and who we've seen have a very large number of potential consequences later on through life. So my question is, and it's kind of a practical question as a pediatrician, when we have 6 minutes, or maybe if we're lucky 10 minutes or 15 minutes, to see that patient and family and put them on one of those two routes, how do we do that?
So I think that the easiest way to do this is to watch carefully and look for red flags. And by red flags, I mean any other symptoms that the baby has other than crying. The crying pattern becomes important, but to my way of thinking, and this is the same way with you evaluate 10-year-old kids with abdominal pain, you look for red flags. And if you see red flags, then you go down that line, and if not, you work with a colleague. And then the other piece of it is, as with any kind of a functional disorder, as painful as it is for the clinician, you have to see them back and work them through it. I remember one mother says, but doctor, how do you know? And I said, I've been doing this a long time. I've seen hundreds of these, and this is what happens, and this is what will happen with yours. And I think that kind of reassurance, and then you see them back and follow up, and you say, see, now it's happening just like we talked about, and whatever, and you can kind of work them through that. But probably the best way is look for red flags. So.
No, I would like also to add some concept because, some babies affected by infant colic could be affected by comic allergy. But in general, in our clinical practice, a lot of mistakes made by the physicians or the pediatrician, also by the families. For example, a baby receiving a mixed feeding, breast milk plus formula. In this case, it's important to recommend also a cow milk-free diet for the mom, and sometimes it's hard to explain to the mom this. Though many doctors start with soy formula or rice formula in infant aged 6 weeks. In this case, it's mandatory to start with an exolycasin formula, or whey formula, or amino acid, not with soy or rice. So it is important, and the duration of the elimination diet to be completely sure that this baby is affected by cow milk allergy. We need no more than 2 weeks. If the baby is recovering in 2 weeks, okay. But if the baby is not recovering in 2 weeks, it's useful to wait and to continue on this way. It's better to consider other conditions in the differential diagnosis, or maybe this baby is affected by a pure functional gastrointestinal disorder. So it's very important to remember every day in our clinical practice, which is the best way to assess, to manage this very common condition, I feel.
So follow-up is very critical.
So I have a slightly strange way of doing it, actually. So I have a probability sort of equation that goes in my head. So the first thing I will do is look at the age of the baby. So if a baby is 14 weeks compared to 6 weeks, the prior probability of this being cow's milk allergy with the red flag symptoms is higher. So the second thing I will go in my head is family history. So I'll sit there and say, right, do they tick the box of prior probability that 2/3 will have a strong family history of A to B? So that's second tick. So my prior probability is now rising. Birth history will be my next prior probability, and look at C-sections, early antibiotic use. So I've got a third tick of prior probability. So now in my head, even before I've asked a symptom, is that I'm more weighted to think that this is a milk allergy. So a 14-weeker who's born by C-section, multiple antibiotics from 2 atopic parents, my prior probability that this is going to be cow's milk protein allergy is already higher before I've even asked a symptom. The second prior probability I will go for is multiple symptoms rather than single symptoms. So if a child is sitting there, back arching stiffening, irritability, loose stools, mucus, blood, red excoriation, my prior probability goes higher. So I literally do it like a probability equation in clinic. And then I would sit there and say, okay, are we looking for red flags on top of it? So I'm literally just clicking through a system and see. And then there's one part that I always add in on prior probabilities, how stressed the family are. Because how accurate is the reporting of the symptoms before I ask a symptom? Because if you've got postnatal depression, you've got exhaustion and fatigue, how they're going to grab the child, how they're going to hold the child is going to be very different. And see. So I literally do it like a click box in my head. And see, and then see. And then just something I want to do with Mead Johnson at some point is that we start calculating those probabilities, and it's like a factor. So you have a 0.7 weighting if you're 14 weeks, then 0.3 weighting then if you're 6 weeks. If your crying is persistent at 14 weeks at night, your weighting factor should be higher. Yeah. So that's where, I showed you COMIS. I think that's quite an interesting way of doing it, but it hasn't got the sophistication. Yeah, so that's the sort of weird way that I do it. Let's see. Yeah. So anyway,
Great. And this is a question for Professor Van der Hoof. It's related to the real colic babies. Which is the consequence in a long-term view?
In a real colic baby, the consequences is that they're normal. They're normal.
They're normal.
Yeah. Parents may not be so normal, but the baby's normal. So.
Yeah.
Thank you. Any other comment from? No? Normal is normal?
No.
Okay.
So perhaps a follow-up question on that. So we talked about the way in which we would distinguish a baby that we think is colicky but essentially normal, and a baby who has allergy. And if as a very busy practitioner, or if you're not quite sure, you might say, because I'm worried about the risk of missing a baby with allergy, what if I just treat this baby who has colic and maybe doesn't need a specialized formula, but what if I treat them with a specialized formula? Are there adverse consequences to that? Is there a risk to that?